Hello everyone, my name is Benita. I am a clinical educator from the Clinical Education Department. Today I present to you a presentation on spinal cord injury and neurogenic bowel dysfunction. The aim of these presentations are as follows. We are going to be discussing what is a spinal cord injury and what do we mean by neurogenic bowel dysfunction. We'll also discuss what is autonomic nervous system and enteric nervous system. How do we manage patients with neurogenic bowel dysfunction, also exploring the importance of nutrition input and the challenges we face in clinical practice while caring for these patients. Spinal cord injury refers to damage to the spinal cord resulting from trauma, for instance, road traffic accident, or from diseases or degeneration known as non-traumatic, for instance, the cancer. World Health Organization reported every year around the world between 250,000 to 550,000 people suffer from spinal cord injury. Around 15 per million cases in the UK are reported alone. Up to 90% of these cases are due to traumatic cases. Symptoms of spinal cord injury depend on the severity of the injury and its location on the spinal cord. Symptoms may include partial, incomplete, or complete loss of sensory function or motor control of arms, legs, or body. Most severe spinal cord injury after are the systems that regulate bowel or bladder control, breathing, heart rate, and blood pressure. Spinal cord injury can affect and change bowel function. The term we describe this is neurogenic bowel dysfunction. The damaged nerve disrupts the ability of your rectum to store and get rid of the waste. This is due to disrupted signals between the colon and the brain, hence you may not feel the urge to have bowel motion, leading to fecal incontinence and constipation. This affects all the aspects of a person's life, including general health, self-esteem, and participation, as fear of incontinence is a common reason for not engaging in activity outside the home and has been described as most life-limiting problem. Normal defecation. Bowel is part of the digestive system, also known as gastrointestinal or GI tract. For individuals without spinal cord injury, the food that is consumed where the digestive works to break down the food for nutrition and energy and eliminates the rest as waste. From the food mixture, which slowly moves to your lower digestive tract, which passes into the small intestine absorbing nutrients. The wall of the small intestine are lined with muscle that contracts and relaxes in a wave-like actions, also known as peristalsis, that pushes the mixture along the path of the small intestine into the cecum of the large intestine. Here, the food mixture is broken down into more and allows to absorb nutrients like vitamins, minerals, proteins, carbohydrates, and fats. Any remaining nutrients and some water are absorbed as peristaltic wave moving into the ascending and transverse colons, reaching through the descending and sigmoid colons. In the rectum, the waste is temporarily stored prior to elimination through the anal canal until a socially acceptable time and opportunity for elimination. The urge to empty the feces intensifies as the rectum fills with feces. There are two muscular rings known as internal and external anal sphincter that surrounds the anal canal and keeps it closed tightly. When the body is ready to use the bathroom, the brain then signals the relaxation of anal sphincter muscles, which then helps to pass feces out through the anal canal. This shows how the brain controls the voluntary action of having a bowel movement, however, also being reminded that there are a series of reflexes throughout the gastrointestinal tract, such as gastrocolic reflex that involves in moving the digestive food to stool along the GI tract. Autonomic nervous system, also known as ANS, regulates the function of our internal organs such as the heart, stomach, and intestines. ANS is part of the peripheral nervous system and also controls some of the muscle within the body. We're often unaware of the ANS as it functions involuntarily. It is most important in two situations, known as sympathetic nervous system, SNS, This is in emergencies that causes distress and requires us to either fight or flight from the situation. This response uses energy where your blood pressure increases, your heart beats faster, and digestion slows down. SNS originates in the spinal cord locating in the thoracic and lumbar spinal cord. Whereas the second one is the parasympathetic nervous system, PNS. In non-emergencies, it allows us to rest and digest. This is when PNS work to save energy where our blood pressure can decrease, pulse rate can slow, and digestion can start. PNS are located in the sacral region and in the medulla, where the cranial nerves are. There are more in-depth information on how these works. Hence, I would highly suggest for you all to have a look at the read link located at the end of this presentation. Enteric nervous system, also known as ENS, is known as second brain or the brain in the gut. It controls the digestive system connecting through the central nervous system and sympathetic nervous system. It has web of sensory neurons, motor neuron, and interneurons embedded in the wall of the GI system, stretching from the lower third of the esophagus right through the rectum. ENS is capable of working independently of the central nervous system. The intestine is the only organ in the body that can function autonomously. When it needs to communicate with the brain, it communicates through the vagus nerve and the gut-brain axis. Like the nervous system itself, the enteric nervous system synthesizes serotonin, dopamine, opioids for pain, and more. It monitors acidity, promotes bowel movement, and monitors our defense level. Types of neurogenic bowel. If you have spinal cord injury, the nerve damage can interfere with the messages between your body and the brain. While many of the reflexes still work, you lose the ability to control a normal bowel movement, known as neurogenic bowel dysfunction, as mentioned above. There are two types of this bowel. The type of bowel will depend on location and extent of the spinal cord injury. First, there is the reflexive bowel, which is in the upper motor neuron, where the level of the injury is on T12 or above. Reflexive bowel, you may not feel the urge or ability to control a bowel movement. Between bowel movement, your anal sphincter will remain tightly closed. Your colon will respond to different types of stimulation, such as digital stimulation or stimulant rectal medications, such as suppository, with normal reflex action that will allow for relaxation of anal sphincter, and the reflex deconstructions of colon and rectum to push the feces out. However, we'll discuss about this a little bit more later on. However, buildup of feces in the rectum can cause reflex bowel movement without warning, leading to sudden or infrequent emptying. Whereas the lower motor neuron, known as areflexive bowel, is where the level of the injury is at or below T12 to L1. It is characterized by the loss of centrally mediated peristalsis and slow stool perplusion. There is loss of reflex coordination where the anal sphincter is loose, also known as flaccid, and could lead to bowel accidents when the feces are collected in the rectum. As the reflex of colon is lost, the use of digital stimulation and suppositories are not effective. Bowel program. Feces must be removed regardless of your spinal cord injury level. Developing an individual bowel routine is a very personal and individual process, which often involves a certain amount of trial and error, especially in the early stages. It is advisable to keep a record of a daily bowel management outcomes, which can be recorded using the Bristol Stool Scale. Also details such as oral and rectal medication used, how long bowel management takes, and whether there have been episodes of incontinence. The aim of the bowel program is to develop regular and predictable emptying of the bowels. This helps to prevent any accidents, constipation, and AD, also known as autonomic dyslexia. AD is a life-threatening condition that can cause death. The most common cause of AD are bowel and bladder distension. Hence, having appropriate patient-tailored bowel plan is vital in management process. AD is presented with symptoms of raised blood pressure, bradycardia, pounding headache, flushing, sweating, or blotching above level of injury. Can also be presented with being pale, cold, or having goosebumps below level of injury. It is as much essential to have bowel plan that is achieved in a reasonable time. Influencing factors when establishing bowel program. When creating a bowel plan, we must consider patient level of spinal cord injury, whether it is in reflexive or areflexive bowel. Also consider individuals' bowel habit prior to injury, such as how frequently did they open their bowel and at what time of the day. Understanding their past medical history, intake of food and drink, level of independence to help them to maximize their confidence in coming days to maintain a good quality of life, and also to consider their psychological and emotional factors. Emotional and behavioral problems may develop or worsen after a diagnosis of spinal cord injury, as it is very undignifying where another individual is needed to help eliminate feces. To overcome this, we do need to promote one-to-one communication, make patient involved in their care, and provide information and education throughout their stay. Also discussing what are their lifestyle and personal goals in oncoming weeks or months. Change or even tailor the care to their preferences. However, please do be honest with the patient with spinal cord injury. We do not want to give them any false hope or false information. Bowel management program. There are two management pathways to carry bowel care. There is reflexive or areflexive bowel. In the left-hand side of the presentation, with the reflexive bowel care plan, it is essential to carry the daily or alternate the days depending on how their pre-injury bowel habits were. Therefore, in the morning, give patients something warm to eat or drink. This helps to form gastrocolic reflex. After half to an hour after food, give patient rectal stimulant suppository. When the patient is ready for bowel movement, take silver trolley in your ward. Place equipment such as box of appropriate size gloves, Optilube gel, bowl of warm water, large clinical waste bag, and Conti washcloth wipes. Grab yourself a colleague who can help you assist with the bowel care plan. This is so that they can help you move patient's position. Prior to doing anything else, always make sure that you get a consent from the patient. Once patient is positioned, place dry washcloth wipes under the designated area where the digital rectal stimulation will be done. Place glove and apply Optilube gel on your index digital finger and start the stimulation in a circular motion. Make sure to stimulate gently and not in a vigorous movement, as this can cause further complication resulting into AD. The feces should start coming out. However, you might have to remove some feces if reflexive evacuation is incomplete. Abdominal massages by the second colleague can be provided to help this. Then single digital check is done to ensure the rectum is empty, 5 to 10 minutes after the last stool has passed. We're aiming for Bristol scale 4 stool in reflex bowel, whereas a reflexive bowel we aim for Bristol scale 3. And we do not give rectal stimulant suppository here, as bowel is flaccid, but we do proceed with digital removal of feces. Also, if there is no result, please do repeat next day and don't leave it out. If there is no changes, then please do make a change of only one element at a time and don't try to change the whole management together. Laxatives are as vital in the bowel management care plans, and these are some of the laxatives that will be provided for our patients with spinal cord injury. Senna is provided as it stimulates the peristalsis of the bowel, which helps to push stool along. It is given 8 to 12 hours prior to planned evacuation only. Bisacodyl is another medication which works within 6 to 12 hours, may cause abdominal cramps and loose stools, hence please do make a report of that and documentation. Sodium docusate, which is a stool softener and has a stimulant effect. We also have lactulose, which is osmotic, which pulls fluid into the bowel and stool, so increases bulk and softening stool. It is taken regularly to maintain appropriate stool consistency. And finally, we do have Movicol, which is a isosmotic and is similar to lactulose, but provides electrolytes to avoid imbalance of the fluids and electrolytes due to excessive loss in stool. Acute management factors. Spinal shock is a result of severe spinal cord injury. It usually requires high-impact direct trauma that leads to spinal cord injury and spinal shock. Characterized as loss of sensation with motor paralysis with initial loss but gradual recovery of reflexes. Reflexes in the spinal cord injury below the level of injury are depressed, hyperreflexia, or absent, areflexia, while those above the level of injury remained unaffected. The shock in the spinal shock does not refer to circulatory collapse and should not be confused with neurogenic shock, which is life-threatening condition. Paralytic ileus. During the spinal shock phase, there will be paralytic ileus. This is a state when the intestine stops propelling the stool. The exact cause of this ileus is unknown. It is thought to be probably due to autonomic nervous system disruption. Onset is usually immediate in those who have sustained thoracolumbar injuries and may take up to 48 hours to develop in patients with cervical injury. It will be treated by continuous suction via nasogastric tube. Aspiration will be performed with extreme care due to suction effect and resulting possible damage to the gastric mucosa. Prophylactic administration of intravenous medication will diminish the risk of development of gastric ulceration during this acute phase. Observation of bowel sound will be performed frequently during the first couple of days. Patient will not be fed until bowel sounds have reappeared, signing disappearance of the ileus. Intravenous fluid infusion and total parenteral nutrition will usually be initiated should an ileus be prolonged for 3 to 5 days. The importance of nutrition. As we know, due to the level of spinal injury, there is physical limitation on what patient is able to do to feed and hydrate themselves. You can involve the occupational therapist who will tailor patient's equipment to the need and their injury. Also, patients with spinal cord injury are highly vulnerable to lack of nutrients, resulting to malnourishment, preventing bone and muscle healing. It is vital to get dietitian involved in early stage once the injury is diagnosed, where they are able to assess and plan patient's diet to help provide with all the essential nutrients in the recovery. Nutrition also helps with the wound healing. It is reported patients with spinal cord injury are highly susceptible to pressure ulcers due to limitation to physical movement. Hence, it is vital that the risk assessments are carried out frequently to see changes in patients' weight, calculating their body mass index, and assessing their skin. As patients' recovery continues, it is shown that patients with spinal cord injury have reduced metabolic activity, meaning that the patients are highly likely to gain weight, where it compromises their health in general. Hence, having involvement of multidisciplinary team, including patient to plan out balanced diet meal, providing fiber intake of 15 to 30 grams, and also encouraging with their fluid intake. Here are some considerations that we would like to take out from the presentation today. It is very important that the privacy and dignity is maintained for our patient with spinal cord injury. As the injury is newly diagnosed, patient may be in emotional shock of the changes that is needed to happen in their everyday usual life. Please make your patient feel involved in every aspect of the journey while they are under your care. Please do educate them on the management of bowel program, or even some patients are expert in the care as they may have lived with spinal cord injury for a long time. Therefore, please do listen to them and educate yourself through them. Bowel care management can be exhausting, hence trial and errors needs to happen in order to have an appropriate plan tailored individually to that patient. Always remember to give your patient something warm to eat, drink in the morning to make gastrocolic reflex in order to achieve bowel movement for that patient. Therefore, we prevent any unexpected accidents during the day or even in the evening. As mentioned in previous slides, vigorous digital stimulation can cause fissures that can cause AD in patients. Since this fissure can happen inside the anal wall, which may not be visible during the bowel care, therefore it is very essential that bowel management is given with lots of care. As you can see with the image here with the disposable glove, this is something that we use in our spinal cord rehabilitation center. It is very see-through and with a very thin material. So it was the best practice to be used in providing the bowel management. However, in the wards here at the moment, we do not have this glove. Using the normal gloves is absolutely fine as long as vigorous stimulation is not provided. Here are a few resources that I would like to have a look after the presentation today. This is the link that I was mentioning in the previous, I believe, at the beginning of the slides on the sympathetic nervous system and parasympathetic nervous system. It just talks a little bit more in depth about how it works in the body. So it's a very good read if you guys would like to have a read. And here are a couple more guidelines and links on the other information on the neurogenic bowel dysfunction as a whole. So if you have any questions or if you would like to provide any feedback, I would be greatly appreciated. Please do drop me an email on b.gurung3@nhs.net or bleep me on 5586. I'm available Monday to Friday from 8 to 4. If you would like to discuss anything about this presentation on a whole, I'm more than happy to. I hope you guys enjoyed this presentation, and hopefully I will see you around in Frimley.